Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes or lecture, which is nothing but a summary of Stand Medical textbooks. So let's continue the topic of diabetes. Previously we discussed till the clinical features. In that we discussed about symptoms and physical examination. Today we will discuss about the must not miss diagnosis, meaning red flags we should not miss when you are seeing a patient with hyperglycemia. You should rule out these diagnoses. The most important two diagnoses in these are two. One is diabetic ketoacidosis and the second is hyperosmolar hyperglycemic state. These two should be ruled out. Let us compare these two. So remember the basic rule. In HHS there will be no ketoacidosis. Ketoacidosis will not be there here, and there will be increased osmolality, and this is common in type 2 diabetes mellitus. Whereas DKA, there is ketoacidosis, meaning change in pH. 1. Number 2, there is no change in osmolality. Osmolality will be normal here. Okay. Number 3, mainly this is a presentation of type 1 diabetes mellitus, and in some cases of flatbush diabetes or ketone prone type 2 diabetes. This is the basic difference in these two cases. Now what are the features? Let us see. So diabetic ketoacidosis, typically the patient is type 1 diabetes, young patient. Glucose will be more than 250 mg per deciliter, and pH will be reduced less than 7.3 or equal to 7.3. Bicarbonate will be decreased less than 18 millimole per liter. Ketones will be strongly positive. Okay. And anion gap will be elevated more than 10 to 12. And mentation, meaning the consciousness of the patient varies from alert to coma. So the differentiating point is the all of these are differentiating point. The basic difference I said. Okay. HHS, the patient is type 2 diabetes mellitus and elderly patient. Glucose level is typically more than 600 mg per deciliter. pH is more than 7.3. Bicarbonate is more than 15 millimole per liter. Ketones are absent. This is very important point. Osmolality is increased more than 320 milliosmol per kg. Anion gap is usually normal, and presentation is usually central nervous system presentation. So presentation is usually a central nervous system presentation. Here involvement of central nervous system takes place after some time, but HHS patient present usually CNS symptoms. Okay. So basic difference I said. So coming to diabetic ketoacidosis, we will discuss these topics in detail in acute and chronic complications of diabetes mellitus, which will be discussed after this diabetes mellitus. So in DKA, pathophysiology and recognition, the trigger is precipitating factors of DKA. First we should see what are the precipitating factors. So it can be a presentation of type 1 diabetes mellitus, or because of omission of insulin, or severe intercurrent infections like pneumonia and sepsis, or a patient having myocardial infarction. So any stressful state, or a patient may have not taken insulin, or it can be a presentation. So these are the 4 important precipitating factors. So when this happens, there is absolute insulin deficiency, and to counter that, there will be a release of counter regulatory hormones like glucagon, cortisol and catecholamines. So what they will do, they will the hormone sensitive lipase which is present in adipose tissue will become uninhibited, and that will cause massive lipolysis to release free fatty acids. So liver gets flooded with these free fatty acids. Okay, so these free fatty acids go into the liver, and glucagon stimulates this carnitine shuttle, where the free fatty acids enter the mitochondria. There they are beta oxidized. Why liver is doing these things? In order to make energy from free fatty acids, because glucose is not utilized for energy because of absence of insulin, so body will use other sources to generate energy. So that's why this is happening in liver. So free fatty acids are utilized as a source of energy, so that will result in the formation of ketone MODYs, majorly beta hydroxybutyrated acetate. So that will result in severe high ion gap metabolic acidosis. Okay, now clinical presentation, rapid evolution from hours to days. So number one is dehydration. So dehydration is a common thing between HHS and DKA. Patient will profoundly dehydrated. Patient will have nausea and vomiting, diffuse abdominal pain, and a characteristic fruity ketotic breath. Why? Because of acidosis, there is compensatory increase in respiratory rate in order to eliminate the carbon dioxide, excessive carbon dioxide. So patient will take a deep rapid sighing breathing, that is known as Kussmaul's respirations. Increased in the hyperventilation will be there. It is not hypoxia. Remember, there will be no hypoxia. So SpO2 will be normal, but still the rate of ventilation is increased. There will be hyperventilation. Okay, not hypoxia. There will be hyperventilation without hypoxia. So that is Kussmaul's respiration. Deep rapid sighing breathing will be there. This is a compensatory mechanism to blow off carbon dioxide and mitigate the metabolic acidosis. Okay, now these are the four important points, which four important clinical features which a patient of DKA presents: dehydration, nausea, vomiting, diffuse abdominal pain, and hyperventilation. So if the patient is not treated, then the patient will develop CNS symptoms. From delirium to coma, the patient may go. Okay, so one important pitfall in management of diabetic ketoacidosis, euglycemic diabetic ketoacidosis. So what that means? So glucose level will be less than 250 milligram per deciliter, but still there is DKA. So this type of DKA happens in three conditions. So number one, in patients who are taking SGLT2 inhibitors. Number two, in cases of extreme starvation. Number three, in cases of pregnancy. So three conditions which we should have a high index of suspicion, although the patient is having a low plasma glucose. That is, patient who is on SGLT2 inhibitors. Nowadays these SGLT2 inhibitors are very much commonly used. And second is patient who is on extreme starvation. And number three, the patient who is pregnant. So SGLT2 inhibitors continue glucose excretion despite falling insulin and rising counter-regulatory hormones. So that will mask the crisis. So result is there will be metabolic acidosis and ketosis, but deceptively there will be reassuring glucose of less than 200 to 250 milligram per deciliter. So critical failure. So just from this we got to know that relying solely on glucose level and failing to measure serum ketones in an ill patient who is taking SGLT2 inhibitors will mask the diabetic ketoacidosis. So patient who is pregnant or patient who is taking SGLT2 inhibitors, don't just rely on the glucose levels, check the serum ketones or urinary ketones also. Okay, so that's about the first thing, diabetic ketoacidosis, the key symptoms, the precipitating factors, and the pitfall. Okay, three conditions we have discussed. So I said that dehydration is common in both HHS and your diabetic ketoacidosis. Now coming to HHS. So remember, in HHS there is one point, there is residual insulin secretion which will adequately suppress the lipolysis but fails to suppress the hepatic gluconeogenesis. Okay, so what will happen then? Glucose will increase, but there will be no lipolysis. Lipolysis will be inhibited. Why? Because there is residual insulin secretion. Whereas in type 1 diabetes mellitus, there is absolute insulin deficiency. That is the difference. That is how DKA shifts to HHS in type 2 diabetes mellitus. So because the residual insulin secretion is there, that will inhibit lipolysis, preventing acidosis. But that amount of insulin fails to suppress the gluconeogenesis in liver. So that's why glucose will increase in the body. So there will be insidious accumulation of glucose. Glucose will be more than 600 mg per deciliter. That will cause osmotic diuresis, profound hypovolemia, and catastrophic free water deficits, so reaching 9 to 12 liters. And because there is a high concentration of glucose in the blood, there is extreme hyperosmolality, more than 320 milliosmol per kg. So this is the reason they present with CNS symptoms, because the neurons get dehydrated because there is a lot of glucose in the blood. So this glucose will pull up the water from neurons, and neurons get dehydrated, and patient will develop immediately CNS symptoms. They present with CNS symptoms actually, HHS patients, elderly patients, along with profound dehydration. So CNS symptoms are significantly common in HHS than DKA. There will be profound alterations in, so what they can present, like they can be present with altered sensorium. Okay. Second, they can present with lethargy. They can present with seizures. They can present with focal neurological deficits mimicking stroke. They can present with fifth one, coma. So may it be hyperglycemia or may it be hypoglycemia, patient can present with CNS symptoms. Both hyperglycemia and hypoglycemia uh, can cause CNS symptoms. That's why in any patient with diabetes mellitus, glucose measurement is very important, because uh, if there is hypoglycemia and you're giving insulin and you're thinking that the patient may be in DKA or HHS, then that will be a very uh, uh, bad thing which one is doing to the patient. So if instruments are not there, and you are seeing a diabetic patient who is unresponsive, but his pulse rate is there, and his respirations are there, then what you do, in case when you don't have any instrument to measure the blood glucose, you just give glucose to the patient. Why? Because if the patient is in hyperglycemic HHS, then giving glucose doesn't matter much. But if patient is in hypoglycemia, then giving glucose will reverse the CNS symptoms in the patient. But if you do the other thing, other way around, meaning if you give insulin, then you are worsening the condition. So in such cases, giving a trial of glucose is a good option when there is no machine to measure glucose levels. Okay, so that is the HHS. So some pitfalls what we do here. So number one pitfall is in HHS aggressive early insulin administration. What it will do? Vascular space in HHS is severely depleted. Initial IV insulin without prior adequate volume expansion precipitates intravascular collapse. Why? So glucose will go into the tissues, and when it is going to the tissues, it will take water along with potassium with it into the tissues, leaving the vascular space empty. That will cause intravascular collapse. That happens in CVS. And CNS, because so much of water is entering into the neurons, so they were dehydrated in HHS. Okay, they were dehydrated in HHS state. Now when you give before correction of the dehydration, if you give insulin, then they become hyperhydrated actually. The neurons will swell and patient will develop lethal cerebral edema. Okay, that's why always in both DKA and HHS, always first fluid correction is required, then measure the potassium concentration, because sometimes potassium concentration will be low in these patients initially, and because you are giving fluid therapy, because of dilution, potassium concentration will fall. Now if you give insulin therapy after fluid correction, that can even exacerbate that potassium hypokalemia, and it can precipitate severe hypokalemia. Okay, that's why initially you should correct the dehydration, then you measure the potassium concentration, then insulin you can give to these patients. So these first pitfall. Second pitfall is, because there is hyperviscosity, there is a very much high risk of thromboembolism in these HHS patients because of high viscosity. Okay, that's why in HHS patient anticoagulation is required. Very important, don't forget anticoagulation in HHS patient. So osmolarity is the thing which is the culprit in HHS. That is second must not miss diagnosis. Okay, so those are the two important must not we should not miss when we are seeing hyperglycemia patient. We should not miss DKA, when we should not miss HHS. So other thing which is a acute emergency, that also we will see, that is iatrogenic hypoglycemia, meaning by giving excessive insulin or taking a high dose of hypoglycemic drugs, you are inducing hypoglycemia in patient. So blood glucose level less than 70 milligram per deciliter is known as hypoglycemia. Clinical presentation will be two, because of two things. One is autonomic nervous system activation, second one is brain is deprived of glucose. The main and central source of energy for brain is glucose. 80% of our body's glucose is consumed by brain. Remember, 80% of glucose of body is consumed by brain. So by that you can analyze, you can have a measurement that how much our brain is dependent upon glucose as a fuel for energy. So that's why a minimal hypoglycemia can provoke symptoms, CNS symptoms. So basically, because of hypoglycemia, there are two things which are affected. So autonomic nervous system will be activated. Second is CNS will be affected. Initially, patient will have autonomic symptoms. There will be increased catecholamine release. Patient will have sweating, very important, trembling, okay, palpitations, intense hunger. These are the four things. 1, 2, 3. Patient will experience these four things. Okay, palpitations, sweatings, tremors, and intense hunger. Initial symptoms. These are initial symptoms of hypoglycemia. Okay, and if these are not treated, then patient will progress to confusion, dysarthria, bizarre behavior, seizures, profound coma. Now, these are CNS symptoms patients which can have. So one important thing, some patients take beta blockers. Okay, and beta blockers will mask the autonomic symptoms, but one symptom they will not mask. What is that symptom? That is sweating. Sweating is not masked by beta blockers. So sweating is a very important symptom in patients with diabetes who are on beta blockers. So that one point we should remember. Okay, now, so there is one thing, something called as hypoglycemia unawareness. What is that? Long standing type 1 diabetes mellitus patient or recurrent episodes of type 1 diabetes mellitus patient, with time there will be blunted counter regulatory epinephrine and glucagon responses. So patient will not have the initial autonomic warning signs. So old patients or patients who are having chronic type 1 diabetes mellitus, so they will develop this hypoglycemia unawareness. So they will not develop the initial autonomic nervous system symptoms. So directly they will develop the CNS symptoms. So this is a thing which we should have in our mind. Okay. And the other thing I already said, non-selective beta blockers will block the autonomic nervous system, but they will not block one symptom, that is sweating. Okay, that one we should remember. Okay. Differential diagnosis of diabetes mellitus. Remember, I said in the pathophysiology only that mainly 4 types of diabetes mellitus we need to differentiate when we have a patient of hyperglycemia. Type 1, type 2 is famous, but we don't focus on this LADA and MODY. Okay, so these 4 major types of diabetes mellitus should be differentiated from one another. Although the most common thing is the type 2 diabetes mellitus, but we should not miss, and the second common is type 1. We should not miss LADA, latent autoimmune diabetes in adults, and MODY. And remember, this LADA is also known as type 1.5 diabetes. Type 1.5 diabetes. Why? It shares the picture of both some features of type 1 and some features of type 2. That's why it is known as type 1.5 diabetes. To remember in an easy way, you think LADA as type 1 diabetes of adults, because usually type 1 diabetes occurs in young patients. Okay, you think LADA as type 1 diabetes of adults and MODY as type 2 diabetes of young. So this is an easy way of remembering these two. MODY is type 2 diabetes of young and LADA is type 1 diabetes of adults. So by this the picture becomes very much clear. Now we will go into the details of these two. And basically, because this is presenting in adults, so we need to differentiate type 2 diabetes from LADA and type 1 diabetes from MODY, because MODY also presents less than 30 years of age, type 1 diabetes also presents less than 30 years of age, and type 2 diabetes occurs in more than 40 years of age, and LADA occurs in more than 30 years of age. So any patient who is more than 30 years of age, differentiate between type 2 and LADA, and any patient who is less than 30 years of age, differentiate between type 1 and MODY. Okay, so that thing we should remember. So similarly we will discuss now. So first we will consider type 1 and MODY. Okay, type 1, the age of onset is usually childhood, adolescence or young adulthood, less than 30 years of age. MODY, same age of onset, patient is young adults, less than 25 years of age, approximately same. Here the body habitus is the patient is lean, frequently recent unintended weight loss history will be there. Whereas in MODY, maturity onset of diabetes of the young, patient will be lean or normal weight. Typically the patient will lack central obesity. Okay, family history is uncommon in patient with type 1 diabetes mellitus. Less than 10% have affected first degree relativity. So that family history is uncommon in type 1 diabetes. Whereas in MODY, this point is important. There is a strong classic autosomal dominant pattern spanning at least 3 generations. At least consequent 3 generations. Consequently, in a successive manner, no gap. Okay, so at least 3 generations, one of the individual in the family will have this diabetes at a young age, at least 3 generations. So this is a very important history in MODY. Okay, autoantibodies will be present, that is like anti-GAD antibody, islet antibody, okay, anti-zinc antibody. They are present at onset in type 1, whereas these are absent in MODY. I said no, It is like type 2 diabetes only, but it occurs in young, MODY. C-peptide levels, endogenous insulin, which is a marker of endogenous insulin, is very low or undetectable in type 1 diabetes, whereas it is initially normal in MODY, maintaining response to stimuli. So this point we should remember. What is that? C-peptide may be low during acute hyperglycemic crisis, meaning like in DKA or HHS, even in type 2 diabetes mellitus. So remeasure the C-peptide after the crisis resolves, meaning if the glucose levels is very much high, at that time C-peptides can be low. So if you want to measure C-peptide levels, measure it when you control some amount of glucose levels. Okay, that is one thing we should remember in case of C-peptide levels. History of autoimmunity will be high in patients with type 1 diabetes mellitus. Autoimmunity history will be high, but there will be no family history of type 1 diabetes. What autoimmune history? History of hypothyroidism or some Graves disease, celiac disease, vitiligo will be there, but that autoimmune history will be absent in MODY. So primary therapeutic treatment in type 1 diabetes is lifelong insulin immediately, whereas it is same as type 2 diabetes mellitus in MODY, that is diet or highly sensitive to patients are highly sensitive to sulfonylureas. I said MODY has commonly three types we discussed. Among that is HNF1 alpha or 1 beta, both of which respond to sulfonylureas and diet. So that's about type 1 and MODY. Now we will discuss about type 2 and LADA 1.5. So age of onset is typically more than 40 years. Now it was 40 years, but now rapidly rising in obese children also. So obese children, you should suspect type 2 diabetes also. Okay. Along with MODY, you should also suspect type 2 diabetes mellitus in children also nowadays, because they are also having obesity. Okay. Body hepatitis, overweight or obese, prominent central obesity, and there will be stigmata of metabolic syndrome like acanthosis nigricans will be present. Whereas LADA also occurs in more than 30 years of age. Patient will be lean or normal weight. Okay. Family history will be extremely common because of polygenic inheritance in type 2 diabetes, but it is uncommon. Okay, uncommon. Family history is present in both type 2 and MODY, but difference is it is not like autosomal dominant which is present for at least 3 generations. It is not like that. That is the difference in type 2 and MODY. So that family history is lacking in LADA. Autoantibodies are negative in type 2 diabetes mellitus, whereas it is positive in your LADA. C-peptide levels are normal or elevated because of compensatory hyperinsulinemia, whereas it is low and progressively declining in LADA. History of autoimmunity will be uncommon in type 2 diabetes mellitus, and history of autoimmunity will be present in LADA. Main treatment is lifestyle modification, metformin, GLP-1 receptor agonist, SGLT2 inhibitors. Here the main treatment is insulin, inevitable progression to insulin dependence. So LADA patients initially they will respond to these oral antidiabetic agents, but very soon they will move on to insulin. Okay, that is how they behave. That's about the 4 major different types of diabetes mellitus. So type 2 diabetes mellitus, more and more it is occurring in children also because of obesity. Obesity is rising in children also. So what is the hazard of misdiagnosing LADA as type 2 diabetes mellitus? Adult with mild hyperglycemia, which is lean, lacks metabolic syndrome signs, and rapid secondary failure on metformin, then you should suspect LADA. Okay, rapid secondary failure on metformin, suspect LADA. Then measure anti-GAD, and if anti-GAD is positive, introduce insulin early to preserve beta cells. So they will have failure on oral antidiabetic agents very much early. That is the very important point in treatment in patients with LADA who is diagnosed as type 2 diabetes mellitus initially. Now, hazard of misdiagnosing MODY as type 1 diabetes mellitus. So young patient who is on insulin, strong multi-generation family history, at least 3 generations, lacks antibodies, and there is preserved C-peptide. So C-peptide is also an important thing which help us to distinguish. So C-peptide and treatment also helps in distinguishing. C-peptide also helps in distinguishing family history, autoimmune history, antibody history, age, body habitus. All these things help us in distinguish these types of diabetes. So if these features are there, suspect MODY, do genetic testing, and if it is positive, transition to oral sulfonylureas to normalize, control, and improve the quality of life. Okay, so that is the important point in management while you are managing diabetes patient. Now MODY we have discussed now, so remember, no need for this one. There is one type of MODY. Actually I said 3 and 5 are like type 2 diabetes only. 3 or 5, 1 alpha and 1 beta. Okay, the difference in 3 and 5 is only having or not having kidney and genitourinary abnormalities. That's all. MODY 2 is just a glucokinase mutation, and patient will have a mild fasting hyperglycemia, mild fasting stable hyperglycemia, which is less than 153 milligram per deciliter, which will not react to any oral antidiabetic agents or insulin also. So treatment is usually not required in case of this MODY 2. That's all. We should remember that thing only. So this is not thing. The more important thing is this one, this table which I explained. This whole stuff is very much important. Okay, now some important things. There is something called as stress hyperglycemia, which is observed during acute illness. So in acute illness like myocardial infarction, sepsis, trauma, there is release of cortisol and catecholamines. They will cause temporary hyperglycemia, which resolves after recovery. But these patients who have stress hyperglycemia, they have increased risk of type 2 diabetes later in the life. That one thing you should remember. Diabetes insipidus is one thing which also presents as polyuria and polydipsia, but glucose levels will be normal. So patient is having polyuria, polydipsia, but glucose level is normal, then suspect diabetes insipidus in these patients. Okay, diabetes insipidus or primary polydipsia or hypercalcemia. So other causes you should suspect. So diabetes insipidus presents with polyuria and polydipsia. There will be defect in vasopressin or ADH action or secretion. So urine will be very much diluted urine and glucose will be normal. So urine osmolality should be checked in these patients. Okay, and there are other some specific tests are there for diagnosing this diabetes. Just we should remember that if glucose is normal and there is polydipsia and polyuria, you should suspect diabetes insipidus in these patients. Okay, I think this is enough for today. We'll discuss next thing like diagnostic approach and management strategy in the next video. Thank you.